Good evening, everybody. Can you all hear me okay? All right. Well, good evening, everyone. I'd like to start by greeting all of you from Boston. So all my greetings to you in the kingdom. I'm happy to be here, and I carry to you salutes from Harvard University and Mass General Hospital. Thank you for connecting. I also would like to thank the Saudi Patient Safety Center for the invitation to connect to all of you. In terms of background, I direct the research group in the surgery department at Mass General Hospital. I'm an associate professor of surgery at Harvard Medical School. I direct the Center for Outcomes and Patient Safety in Surgery, which is the quality and safety umbrella for 12 of our departments like surgery, anesthesia, OBGYN, neurosurgery, orthopedics, etc. Having said that, I am also a very active surgeon, trauma and acute care surgeon, and I operate more than 3 to 4 days a week on a routine basis. I actually just finished surgery now. And the reason I am telling you this is I am a big believer that patient safety should always start and end at the bedside. I think it has been a little bit of misadventure that we took away patient safety and quality from the bedside, from the nurse at the bedside, from the physician at the bedside, from the surgeon in the operating room, and it sat for too long on the chairs and on the desks. So I believe patient safety should always start and should always end at the bedside. This is my plan for you today. We have about 2 hours. I plan to stay on time. I would like to request from all of you to keep the questions till the end. I'm going to try to leave about 15 minutes for interactions. And I would be really, really interested in your thoughts in the end. But to allow this for the discussion to happen, we'll go through over some slides, and then we'll leave questions till the end. This is my plan for you for today. I told you it all starts at the bedside. So here are 3 cases, and we will plan our slides and talk today according to these 3 cases. The first one is, did you remove the wire? Which will let us talk about how we talk about safe system design and how we go from blame to safe system design. The second one is, we have some serious bleeding, which I will use as a pretext to talk about how we should measure and how we should predict adverse events and complications in surgery or in the perioperative setting. And the third one is, dude, your patient is going down the drain, where I would introduce the concept of the surgeon or the physician or the nurse as second victim. So this is the first case, and all these cases are real cases that happened here in the United States, and I happen to be involved in these cases, not personally as a clinician, but some of them are my personal cases. So this is the first case. Now imagine you are a second-year resident training in surgery. It's your first month on the rotation. You're covering one of the cancer satellite hospitals. You happen to be covering more than 50 patients at night. You are the highest authority that night in the hospital. And in the middle of a busy day, the fellow comes and requests that you put a central line in this sick patient in the ICU. It's about 5 p.m. The fellow says, you know how to put a central line, don't you? And of course, as a good surgical resident, you go, of course I do. I've placed a few in my internship and I know how to do it. Then everybody left and you prepped everything correct. You're trying to place that line and your pager starts going off. And you can't because you're in the middle of the procedure. So a code blue, which is a code saying there's somebody who had a cardiac arrest, goes in the speakers of the hospital requesting that the surgical resident comes to the bedside of another patient. You know this is a patient you're covering, so you rush very quickly. You finish the central line, and you run to see that code. Unfortunately, that patient does not make it. And then you come back to see the chest x-ray on the patient you just placed a central line on. And to your surprise, this is the x-ray, and you can see it projected there. And I'm sure many of you recognize immediately what's going on here. You can see that resident has left the wire during trying to do the Seldinger maneuver to place the central line. That wire should not be in the body, and now it's in the body. It's a completely technical error, happens very rarely, but what should the resident be? Is the resident just a bad resident that did a mistake and should be disciplined, should be fired? What should we do? In the Mortality and Morbidity Conference, the resident stands up, owns to his mistake, and say, I messed up. Is that enough? Did he mess up? Yes, he did. But is that really what's going on? So what I want to show you in the next few slides to go is that it's not only about people. The system is as important as the people. And if we design a safe system, we can prevent these errors even when people do mistakes. So, can I go back in history a little bit? This is Hippocrates. And the first rule of Hippocrates in Athens back in the day was first, do no harm to patients. And right now we still say the same thing every time we swear when we become physicians. We swear that we should not do any harm to patients if we can. If you advance about 1,000 years ago, this is ALBUCASIS, who lived in Cordoba between the year 936 and the year 1000, or ALBUCASIS al-Zahrawi in Arabic. And this is what he said to his residents. He said, you must know, my sons, that operative surgery is divided into two parts. One where surgery is safe to the patient, and one, on the other hand, that most often results in patient harm. You advance a few hundred years more, and this is J. Marion Sims. He's the father of OBGYN surgery in the 1800s. He has a statue in Central Park in New York if you ever visit. And he was not as nice as ALBUCASIS al-Zahrawi. What he said is, I knew nothing about medicine, but I had sense enough to see that doctors were killing their patients, that medicine was not an exact science, that it was wholly empirical, and that it would be better to trust entirely to nature than to the hazardous skill of doctors. You advance another 50 or 100 years, this is Ernst Codman. He actually was working at my own hospital, at the Mass General Hospital in Boston. And he said, when we do mistakes, we should be measuring them, that every hospital should follow every patient it treats long enough to determine whether or not the treatment has been successful, and then to inquire, if not, why not, with a view to prevent similar failures in the future. And I'm not sure if any of you knows the story of Codman, but in the beginning of the 20th century, his ideas were so drastic and so dramatic that we kicked him out of Mass General. We thought he is too much of a radical, and we removed him out of Mass General. It's only 100 years later that we realized the importance of the thoughts of how safe we should be and how we should be measuring safety and acting on it to prevent similar failures in the future. So the question, all of these quotes are more than 100 years, up to 2,000 years ago. So are we delivering safer care in surgery these days? This is a slide I borrowed from a friend of mine called Tom Weiser, and he tried to estimate how many surgeries we do globally in the world every year. And if you look at the right-hand side here, you can see that we do, the numbers are now even more. We do about 250 million surgeries in the world every year. And the burden of surgical disease and how we define it is increasing tremendously. And that's much more than how many childbirths we have, prevalent HIV cases, or incident HIV cases. If you do a little bit of a simple mathematics, we know the risk of surgical complications ranges between 3 and 16%. We know the risk of death after surgery is somewhere around 0.8%. So a little bit of mathematics tells us we're still dealing with 7 million complications every year in the world, and at least 1 million patients who die after surgery every year. Actually, there was 2 reports that appeared in the last 20 years in the United States. One is called To Err is Human, and one is called Crossing the Quality Chasm. And in those 2 reports, which I encourage each one of you to read, at least read some parts of it, you can see that medical errors comes right after heart disease as cancer in terms of causes of death in the United States. To the point that if you look at healthcare in general, as compared to other industries like the airline, the nuclear plants, and you look at how reliable we are, and reliability is measured in terms of the ability to deliver what we promise the patients to deliver out of 100 times of these promises. So for example, the airlines, when you board on a plane, you're supposed to go to a certain city. You can bet that 999 times out of 1,000 you will be in that city. So that's a high reliability. It's an excellent safety profile industry. The same thing goes for nuclear plants. When you look at trains and ground transportation, it's somewhere in the middle. Chemical manufacturing is somewhere in the middle. And if you look at healthcare, we're actually, from a reliability and safety profile, we're almost put at the level of mountain climbing. So now it's still a lot of work for us to do in terms of healthcare safety. But we're talking about errors, we're talking about adverse events. I thought it's important, before we dive into this a little bit more, to know what the terminology that we all agree on. There's a difference. An error is defined as a failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. An error might not result in an adverse event, and an adverse event might not be an error. And it's important to distinguish between the two. An adverse event is an injury that results from a medical intervention or management. Again, many errors cause no injuries, many errors cause no patient harm, and many injuries are not necessarily caused by errors. And it's important to distinguish between the two. In terms of patient safety, it's important to also shift our minds of how we think of patient safety in surgery. Errors are normal human behavior. All humans make errors, and all humans make errors every day. We give most people the benefit of the doubt. Most people do not make the error on purpose, and an error is not necessarily a misconduct. And it's important to know that every system is designed to deliver exactly the same results it delivers. So adverse events and errors result from bad systems and not necessarily bad people. It does not mean that we shouldn't hold people accountable when there's an error, where there's an adverse event. But I think it's important to shift our mind to think of the system and how can we design the system in a way to prevent the error from happening. Latent error is a human error likely to be made due to organizational culture and system design that are formed in such a way that humans are disposed to making these errors. Its effects can lie dormant in the system for a very long period of time until the opportunity for that error to happen and manifest an injury to patients. So if we go back to the case, the surgical resident that left the wire in, we can blame the surgical resident, say that resident is a bad resident, is not technically safe, and we can just fire them and let them become a surgeon. But it's also important to look at it from the Jim Reason's model, which what we call the Swiss cheese model. The Swiss cheese model is a kind of a caricature of how we should think of safety, but it makes the point very clear. What it is an injury to a patient or an error to a patient does not happen in the void. It happens because in the system, there's these kind of slices of cheese, and each slice has multiple holes in it. And it needs a lot of these holes to align for a hazard that the patient is exposed to result in an error and an injury and a loss to the patient. So if we go back to this case, this is what's going on. There is the old surgical culture, for example, that when your senior asks you to do something, you just say, yes, sir, I'm about to do it. I can do anything. The resident themselves have not been sleeping well for a whole month on that rotation. They've been taking a lot of calls, so there's a little bit of fatigue involved. It's the first month of the second year residency. They don't have enough supervision. They are covering way more patients than they need to be covering, 50 patients alone. And now the one thing that happens, there's another patient that's coding at the same time, which throws the resident off their comfort zone. They have to rush through the central line. It's still not a second nature to them, and the error appears. So how do you overcome that? From a conceptual point of view, the way to overcome the problem is to design your system to have as many slices of cheese as possible and as smaller holes than you can. And if you do that, when a patient is exposed to a hazard, one of the slices of your system will stop that hazard from reaching the patient. In other words, a safe system design has to have three things. It has to be redundant. A system that's redundant, that has multiple checks on the same process, is a safe system that an error will be caught because of the redundancy. Reliability. It has to have the ability to deliver what it's intended to deliver in a certain amount of time, deliver it over and over again. That's why standardization is really important, because if you always provide the care in a very similar fashion for the same kind of patients, that allows less variability, non-patient related variability of the surgical care. And if a patient needs something different, or a patient is behaving a little bit different than you expect them, then it's easier to see that patient and tailor the care to them, but within this kind of standardized way of doing things. So if we take a small second and see, what do we do now? Our problem now is that we do most of the right things on most patients most of the time. And this is not good enough, because with a small piece of logic, another way of saying the same sentence is, we fail to do all the right things on all the patients all the time. And that's what we should be doing. And a good example of that, of how we should be doing all the right things on all the patients all the time, is the Safe Surgery Saves Lives initiative that was created by WHO a few years ago. And I know many of you are familiar with it. And I was fortunate enough to be part of that team back about 12 years ago when we were designing the initiative. The goal of the Safe Surgery Saves Lives initiative was to promote surgical safety as a public health issue, create a checklist to improve the standards of surgical safety, collection of the surgical vital statistics, and had 10 objectives. The team will operate on the correct patient at the correct site, will use methods known to prevent harm from anesthesia while protecting the patient from pain, will recognize and effectively prepare for life-threatening loss of airway or respiratory function, or recognize and effectively prepare for the risk of high blood loss from hemorrhage, will avoid inducing an allergic adverse drug reaction. It will consistently use methods known to minimize the risk of surgical site infection. The team will prevent inadvertent retention of instruments or sponges in the surgical site. The team will secure and identify all surgical specimens, effectively communicate across the anesthesia, nursing, and surgical team. And hospital and public health system will establish routine surveillance of the surgical capacity, volume, and results. So a lot of you are familiar with this specific format of the checklist. It's a very low-tech answer. I know a lot of hospitals have tailored it to their needs, to their specific hospital format, to their specific hospital culture. I know some of you use it in English, some of you use it in Arabic, but all are familiar with the sign-in component of it, the time-out component of it, which happens right before the skin incisions, and the sign out before the patient leaves the operating room. And I am sure a lot of you are doing it on a daily basis, at least one form of it, of each other. So this was a low-tech answer, but did it work or not? And that's what's impressive. We have all the robotics, we have all the laser machines that we do surgeries with, and here's a checklist that we applied at that time as a research team in multiple sites all over the world to see how much difference does it make. And at the essence of it was a safety culture. This was the article, if anybody wants to read it, was in the New England Journal of Medicine, a surgical safety checklist to reduce morbidity and mortality in a global population. But this was the eye-opening finding that we had. You look at cases, this is at baseline before the checklist and with the application of the checklist. And you can compare death. So patients dying after surgery went from 1.5% to 0.8% just with the systematic use of the checklist. The rate of complications went from 11% to 7% with the use of the checklist. Infection, surgical site infection, went from 6% to 3%. Unplanned reoperations went from 2.4 to 1.8%. Everything got better. Now, a lot of it, again, people think it's a sheet of paper and that's what results in the improvement in outcome. And perhaps just the fact that we're measuring, we're watching. And that is true. That is component of the results we found. But a lot of it is the change of culture and us doing, instead of doing most of the right things on most patients most of the time, we're not doing all the right things on all the patients all the time. Then people said, well, it's only the low and middle income countries that benefit from it. But when we looked at the high income countries versus the low and middle income countries, the same results were there. The rate of death and complications decreased in the high income as much as in the low and middle income countries. So this was not purely a low income country problem. Since then, you can see a lot of hospitals all across the world have been using the checklist, and it became part of the standard way of how we do surgery in general. So going back to the mathematics, low tech, easy math, 234 million people operate on each year, more than 1 million die from these complications. Half are avoidable with a systematic checklist and a change of culture of how we do things. You're talking about almost 500,000 patients that we could save by doing, instead of doing most of the right things on most patients, most of the time we do them all the time on all patients all the time. So that was the first kind of your introduction to patient safety. Now I want to talk about another case. And from that, I want to talk about the importance of measuring. So this is the second case. And I don't know how many surgeons we have on the list, but even if you are a nurse that involved with surgical patients, anesthesiologists, you will all recognize this case. So imagine you're a surgeon, if you're not, and you're doing a complicated colon and liver resection. Everything is going well. The music is in the room. You're listening to music. And like most surgeons, you're sometimes wrong, but you're never in doubt. You avulse the spleen as you're trying to take the splenic flexure to take that colon out. There was a little bit of scar tissue from the prior surgery, and now the spleen is bleeding. It's audible bleeding. The music is down. The patient's blood pressure is going down. The patient is getting sick. You ask the anesthesiologists to get some blood into the room to resuscitate the patient. They do a fantastic job, and they salvage the patient. But you're such a good surgeon. You fix the problem. The patient only required 3 units of blood later. The spleen is out. Everything looks good. The case is finished. So the question to all of us. So now, okay, we did an intraoperative adverse event. The spleen was not meant to be removed, was not meant to bleed, but now everything looks good. Is the patient all good? Did the complication end in the operating room, or does what happens in the operating room translate to how the patient will do after surgery? Is it an error? Is it an adverse event? Is it non-preventable? Is it preventable? A lot of thoughts should go into us, and that's the second section of what I want to talk to you about. Measuring adverse events and complications. So here's another thought. If you want to take a few learning points from the webinar today, the first one we talked about is, patient safety should always start and end at the bedside or in the operating room. Here's another one for you. You cannot improve what you do not measure. You think you can improve what you do not measure, but if you do not measure what you're doing, you don't measure where you are and where are you reaching with the interventions you're doing, then you have not improved it. But I also take it another level. You cannot improve what you do not measure in an accurate fashion. What you do not measure in an accurate fashion, risk adjust and benchmark. If you are the surgeon, anesthesiologist, or the nurse taking care of the sickest patients, if we measure only mortality and we say, well, it looks like this surgeon has a lot of patients that died versus another surgeon who's doing very low acuity cases, has never had a patient die. If you don't risk adjust in a very robust way, you can erroneously assume that the surgeon taking care of the sickest patients is the one that is not a very good surgeon. So in the next few slides, I want you to all think with me and see why is this important with a specific focus about what happens during surgery. The three real questions, if you believe with me that you cannot improve what you do not measure accurately, what you do not risk adjust, and what you do not benchmark, the three questions that we have is, what should we measure? What data should we use to measure what we want to measure? And how and what level do we benchmark? And benchmark is a terminology that we used to say we need to be comparing. And should we be comparing hospitals to hospitals, countries to countries, surgeons to surgeons, divisions to divisions, and so on and so forth? And these are the real three questions that we need to address. What do we measure? These are some of the things we should be aiming to measure and aiming to perfect how we measure, and none of them is where they need to be. There's still a lot of work being done in a lot of places, including our own group here in Harvard and Mass General. We're trying to measure these and make it as useful as possible. But intraoperative adverse events, when we injure something during surgery or when something goes wrong during surgery, mortality, process measures. So sometimes the outcomes themselves are they're very important, the ultimate important things, but a process measure, meaning how many times are we doing what we are supposed to do out of 100, is really important so that we see if we have a problem before the outcomes of the patients are affected in a bad way. But we should also be measuring 30-day, 60-day, 90-day, as long as needed. And in some patients, it's important to measure a year down the road how they're doing. We should be measuring infectious complications, renal complications, cardiovascular complications, pulmonary complications, neurological complications, gastrointestinal complications. But I also take it a step further. We need to be measuring the quality of life of that patient. I might do a very good surgery that the patient recovers from fine without any complication. But if the patient's symptoms have not improved, if the patient is having a major quality of life problems, they're not able to carry their life like they were supposed to carry it, then that's something we need to be measuring as well. And that's part of our safety and quality duty to these patients. If you ask me what was the major safety success in the last 30 years, my answer is very, very clear. In the United States, and now it's spreading in multiple areas in the world, National Surgical Quality Improvement Program for surgical patients has been the major breakthrough. And to give you a little bit of a historical background of what that is, so NSQIP, or we call it NSQIP, the National Surgical Quality Improvement Program, is an initiative that started back in 1992 in the VA, the Veterans Affairs component of the healthcare in the United States. Because in 1985, the media was coming very hard on the VA hospitals, saying that they have a high mortality and morbidity. And the Congress established a public law asking that we need to improve that. The quality of care is not good enough. Just do it. Just do whatever you need to do. And the picture you have up there is for Dr. Shukri Khoury. He's a fantastic surgeon. He was a cardiac surgeon here at Harvard, and he was one of my teachers back in the day. Unfortunately, he passed away a few years ago, but he started the whole NSQIP movement here. And he created the NSQIP, and it was a very simple idea. They created a list of what matters, the risk factors, the age, the demographics, the comorbidities that matter before any type of surgery, then created a list of variables around what happens in surgery, what kind of surgery is the patient having, and then they created a list of 20 complications they wanted to measure up to 30 days after surgery. And then they created standard definitions of how each variable should be collected. And they said every hospital in the country should be measuring that and reporting it centrally. So that was the 1994 creation of the NSQIP. And just by the pure creation of NSQIP and sharing the data of every hospital compared to the rest of the nation, that by itself led to an immediate, within 2 years, 27% reduction in surgical mortality in these hospitals and 45% reduction in surgical morbidity. The way it worked is, if you're a hospital that you thought you're doing very well, and suddenly you see your hospital compared to the rest of the nation that we actually have a higher mortality, everything else being equal, meaning they looked at, compared to the rest of the hospitals, compared to your patients, how sick your patients were, how morbid your patients were, your mortality is higher than expected. Then you knew you had a problem, which made that hospital dive into the details and figure out how they can improve. Within a few years, more than 300 hospitals, VA hospitals in the country took it, and a few years down the road, now there is thousands of hospitals in the United States and a few hospitals outside the United States that are part of the NSQIP model, and that's how I think that was the best thing that ever happened, is because we measured. Before that, we thought we were doing well. Now we knew we're doing well or we're not doing well. So measurement is power. This is what we measure now in my own hospitals. And you can see on the right side here, you have mortality rate, morbidity rate, return to the operating room, length of stay. And this is my own personal numbers. You can see my name written there. And this is the mean number of complications, how many percentage of complications I had of surgical site infection, wound dehiscence, sepsis, DVT, PE, cardiac arrest, all these complications. And you can see I have more data. This is coming from what we call Visian, the University Health Consortium, another way of measuring. And you can see I have the length of stay of my patients, the cost component, the readmission component. We're looking at early death and mortality, and green is good. Red is my division, how they compare to the average, and so on and so forth. And you can see that we're very hard on each other. And if you're looking in the red, then you need to be improving something. And I get that at least twice a year and sometimes up to 4 times a year. I'm the only one who sees my own complications, but it's an incentive for me to improve what I do, to see if I have something that I need to improve. But I also get a list of my process measures. I see how many of my patients who are supposed to get antibiotics got their antibiotics on time. And that's me compared to the average. I get how many patients of mine who need to have prophylactic antibiotics discontinued within 24 hours, how many of my patients had the same process measure fulfilled, and so on and so forth. You can see all these are specific process measures. They're not harm or complications, but just how am I doing in terms of providing my patients with the best care that we know to provide. What data should we use? So we should be measuring outcomes. We should be measuring outcomes short-term and long-term, but what data should we use? Traditional M&M, which is what we did for many, many years, have been studied over and over again. And we have less than 25% sensitivity in detecting adverse events. Imagine that 3/4 of the complications that patients have, even in the best hospitals in the world, 3/4 of them are missed and are not being presented in mortality and morbidity conferences. We could review every single chart like we do in NISQIP, like we do in the Trauma Quality Improvement Program, like we do in the Metabolic and Bariatric Surgical Quality Improvement Program, or the Thoracic and Cardiac database. We do that, and they actually tend to be very accurate databases, but the problem, they're resource intensive. They require a lot of people and a lot of time from these people to be able to collect the data. So an alternative came, which should we look at administrative data? We do the ICD codes, the CPT codes, the DRGs. It's the data is already collected, mostly for billing and insurance purposes, but perhaps that's a way of doing it. And that's what the patient safety indicators were created for. And I'll go into a little bit of the details of how we measure patient safety through the patient safety indicators. And they have an advantage. Administrative data has an advantage. It's readily available. It is very low cost. And actually, you can do some risk adjustment to it. But the problem with it has always been that its validity is questionable. How accurate it is very questionable. So we looked at that. How accurate is administrative data to identify patient safety-related events and surgical adverse events? And we looked specifically at the patient safety indicators. So this is a list, again, from my own data. You can see there's 15 patient safety indicators that are reported. These were created by the Agency for Health Research and Quality. Back about 15 years ago, I'm gonna say, and they were meant initially, which I think I have there. They were meant initially to screen for potentially preventable adverse events. It's an initial screen that you throw on the big database that you have, and you see if some patients' charts will flag that something wrong happened in that chart. And that will trigger a review to see if something bad happens. So what are they? They're really elaborate algorithms based on hospital discharge administrative data. Again, ICD codes, ICD-9, now it's ICD-10, and DRGs. They were designed by HRQ, but they were later endorsed by the National Quality Forum, endorsed by the Centers for Medicare and Medicaid as ways to measure quality and later on pay for performance. So this is some of these patient safety indicators, and you can see their definitions. Now I gotta go into each one of them, but we'll take a few. Complications of anesthesia, death and low mortality DRGs, which is in-hospital death per 1,000 patients in DRGs that are supposed to not die. This is the patient who has a spine surgery, for example. They're supposed to be elective, go home in 1 or 2 days, and something bad happened. They get a fulminant C. diff infection. Next thing, they're sick in the ICU. They need a subtotal colectomy, and they die in the ICU a few days later. So this would be caught by that patient safety indicator. Decubitus ulcers, failure to rescue, which is pretty much defined at out of the patients who have some complications, how many end up dying, meaning we fail to rescue them from the complication. Foreign body left during the procedure is PSI number 5. Iatrogenic pneumothorax, which is when we cause the pneumothorax by an intervention, whether it's a central line or whether it's a pleural tapping or whether it's from surgery itself. You look at patient safety indicator number 8 is postoperative hip fractures, meaning the patients fell down due in the hospitalization. Postoperative hemorrhage or hematoma, this is the patients who bleed after surgery. Postoperative physiologic metabolic derangements, and a lot of these are the renal failures, patients who get renal failure after surgery, or they can get electrolyte imbalances like hyperkalemia or hyponatremia. Postoperative respiratory failure, patients who fail from a respiratory point of view, and a lot of them require intubation and an ICU admission. Postoperative pulmonary embolism or deep vein thrombosis. Postoperative sepsis. Postoperative wound dehiscence. Accidental puncture laceration, and transfusion reactions. So these were the indicators that the Agency for Healthcare Research and Quality designed about 15 years ago to try to measure patient safety and improve patient safety through it. I'll take one of them to give you an idea of what they really are. They're electronic algorithms, and it's a combination. There's a numerator and the denominator. So looking at the administrative database, you see what things will make a chart if get flagged if any of those codes appear. The denominator is all surgical and medical discharges 18 years and older, and you have some exclusion of cases. For example, you exclude patients with principal diagnosis denoting accidental cut, puncture, perforation, laceration, patients who are pregnant, childbirth, and so on and so forth. And you can see that it's kind of has the algorithm will look automatically at the data. If something fulfills all the numerator, fulfills all the denominator, and does not meet any of the exclusion criteria, it would flag this chart, and we go review it and see if a patient safety related adverse event happened. So these patient safety indicators, or key performance indicators for surgery, they were intended to be screening tools, maybe a way to do some quality improvement efforts to monitor safety of clinical care over time. But as time went by, they started getting used more and more for hospital profiling, public reporting, and pay-for performance, which was not part of their initial intended use. So the question always comes, do these performance indicators really measure what they're supposed to measure? There was a lot of controversy here, as well as in many areas in the world. How accurate are they? Now, over the next few slides, it's important for all of us to understand their strengths, but also understand their weaknesses so that we can improve the system in an accurate fashion. So over many years, I was part of the team that the government requested that we validate these and see if we do, and we validate them recurrently in multiple publications. And if people reach out in the end, I'm happy to send you any publications you want about this topic. And we try to measure that, like how accurate are these? Are they really measuring what we thought they are? And this is the summary of what I want you to see. They are not all created equal. Some of them are good. Some of them are very good. And some of them are not good at all. So when people want to come to you, whether you are the quality manager, or whether you are the safety officer in the hospital, or whether you're a surgeon, a nurse, anesthesiologist, it's important for you to develop some knowledge of what these are so you can have a meaningful conversation about them. For example, in this study that we did and was published about 9 years ago or 8 years ago, we had almost 2.5 million patients. And when we looked at postoperative PE-DVT, which is the patient safety indicator number 4, we measured what we call positive predictive value. The positive predictive value is out of 100 cases that the algorithms flagged as postoperative PE-DVT, how many were true? How many were correct? How many times was the algorithm correct? And you can see for PE-DVT, it's only 44%. It's lower than the flip of a coin. That patient safety indicator is not ready, or was not ready for prime time. It's not ready for us to say to a hospital, you have a problem, you don't have a problem in PE and DVTs. We look at accidental puncture laceration. That was much better at 85%. You look at iatrogenic pneumothorax. That was 80%. Postoperative sepsis, 62%. And postoperative wound dehiscence was the best one at 89%. So not all of them are equal. Not all of them should be used with the same level of confidence. And when we looked at other ones, this is foreign body left in. It was only 46%. We looked at postoperative hemorrhage, was only 75%. Postoperative renal failure was only 67%. So why were these indicators failing? And that's another area we looked at. So this is, for example, PE-DVT. I told you it's about 44%. Why was the algorithm incorrect? Why was it doing so much wrong? 14% of the time, the PE or the DVT was present on admission. This is the patient came with a DVT and was coded as having DVT history or active DVT, but that was not a complication of surgery. 13% of the time, the patient comes in is in the medical ICU, for example, gets a DVT and after that requires a surgery. The algorithm did not have a time component to it, so it will detect it as a post-operative PE DVT while we know this happened before the surgery. Old history was another problem, and there was 21% of the cases were just purely inaccurate coding. For example, this is a patient who had an arterial thrombosis, a vascular surgery patient. This is not a deep vein thrombosis. This is the patient that had an event and somebody wrote in the chart, rule out PE as a cause of death, and it still got coded as a PE, well, we don't have any evidence that was really a PE, and so on and so forth. And you can see that it matters how the billing and the coding is happening for these algorithms to be correct. Same thing for pneumothorax. You can see present on admission about 9%. And you can see accidental puncture laceration. There was also some related inaccurate coding. And you can see we have all the numbers for all the patient safety indicators. Some of them are good. Some of them are as low as 30%. And the best one is about 85 to 89%. So it's important for anybody at whatever level, the clinician at the front, the one who's taking care of the patient, the one who is managing and measuring, to understand what these patient safety indicators mean, how accurate they are, and to know that they're not all equal, so you can actually target your interventions to improve safety and quality in surgery to where you need to be. So this is the same thing. This is the reasons. It was always the same thing. A lot of miscoding, a lot of coding specificity does not exist. A lot of recommendations we gave, and we improved some of these algorithms. A lot of them are doing better now than a few years ago. But we recommended that using them for clinical and quality of care purposes may require modifications. And we even suggested, we said, we need to adjust some coding guidelines. We did create present on admission flags to tease out that component of the problem. Timing codes, standardized coding practices, but also educating and training the medical coders, since we're using them for non-billing. But then we said, until coding revisions are implemented, these patient safety indicators, specifically PE-DVT, which is one of the worst ones, should be used primarily for screening. It's a net to discover, to dive into, but they should not be used for reporting and pay-for-performance needs. I told you we're going to dive a little bit more into what I call the Pandora's box, or the black box of what happens in the operating room. And this is an area of special interest to me. We've done quite a bit of research in it in the last few years. But most of us, as you can see from what we measure, what we get, we focus a lot on optimizing a patient, on how we take care of them post-op. We measure everything post-op. There's whether we do the right surgery, we don't do the right surgery. But the operating room has for a very long time remained this black box. Nobody knows, besides the surgical team that was in surgery, what happens, and nobody's talking about it. You finish the surgery, what happens in the OR for a very long time stayed in the operating room. So we tried to open this Pandora's box. We said this is a safety related thing we should be measuring, and surgeons should be at the forefront of measuring this problem and talking about it. And that's what I want to talk to you a little bit about it. Because if we as surgeons, anesthesiologists, nurses, and everybody do not measure it ourselves, then somebody else is going to measure it, somebody who does not understand the nuances of surgical care and operative care and perioperative care. And it's already happening, at least in the United States. You can see now, you can go to consumerreports.org, like if you want to buy a fridge, and you can go to this and see which brand name of fridge you can buy, which one is the best. And the same thing is happening to hospitals and even to surgeons at this point. You can say, I want to have my surgery in this hospital X, Y, or Z, and you can see their safety score, but you also can see the rate of surgical adverse events. And I hope to show you in the next few slides why we should be doing this measurements rather than have somebody other do it, because there's a lot of nuances that we need to measure and include in our measurements to be able to tell what hospital and what surgeon and what surgical team is really the best equipped to take care of you when you need your own surgery. So this is what we've been doing in the last few years. This is IAE, or what I call intraoperative adverse events. And we've been trying to measure a lot of aspects of it to not make it stay a black box, if you want. So we need to understand what risk factors are very specific to intraoperative adverse events. We need to understand how the occurrence of an intraoperative adverse events, like the patient who had the spleen injured, the case we started with, how does that translate into how the patient does? What is the risk of this making them die, not during surgery, but after surgery? What is the risk of them getting more complications, whether they get pneumonia, whether they get respiratory failure, renal failure, anything after surgery? How does that make the patient likely to be readmitted, stay longer in the hospital? But how do we measure the severity? You can have a small injury of a serosal bowel tear during surgery. You can also injure the aorta, and the patient requires 30 units of blood. So the two are not equal. But we also need to see what is the financial impact on the healthcare system as a whole of the occurrence of intraoperative adverse event. How about operating at night? Does operating at night lead to more? Should we only be operating at day because we're tired at night, and that can lead to more errors during surgeries? How about experience of the surgeons? Do less experienced surgeons do more complications during surgery or not? How about the resident or the trainee that's assisting? Does that matter or not? So, going into these little bit of details, let's talk about severity in a little bit. Again, if you email me after the webinar, I'm happy to send you all the articles that I talk about and I mention here, but this is an article that was published in the Journal of the American College of Surgeons, what we call the Blue Journal here. And we derived and validated a novel severity classification for intraoperative adverse events. And I can go into details spend a lot of time talking about how we did it, but I'll save you the details. And this is what I want you to see. A class 1, this is only for injuries during surgery. A class 1 is an injury that required no repair. So this is the lowest severity, and most of the operative reports do not even mention them. Class 2 is injuries that require surgical repair without organ removal or a change in the originally planned procedure. For example, you injure the bowel and you have to repair that bowel, or you need to do a patch repair of a vessel that you injured. Class 3 is an injury requiring tissue or organ removal with completion of the originally planned procedure. Class 4 is an injury requiring a significant change and or incompletion of the originally planned procedure. So class 4, for example, you're doing a laparoscopic cholecystectomy, you injure the common bile duct, and now you have to actually do a major reconstruction and a hepatocogenostomy. That'll be a class 4. Or you injure the aorta, the patient bleeds so much that you end up leaving the abdomen open after you pack and come back another day after you control the hemorrhage. That'll be a class 4. That's compared to class 3, which we just mentioned. This is, for example, the splenectomy that we talked about in the initial case, where you had to remove the spleen because of your injury. That'll be a class 3 injury. Class 5 is if you miss the intraoperative injury. You do an enterotomy and your laparotomy while you're doing the resection. You did not pay attention to that. You did not discover it. And the patient gets sick in the first few days after surgery. It requires reoperation. That's a class 5. And a class 6 is an intraoperative death. And we add a suffix T if the injury was a vascular injury and required transfusion of at least 2 units of blood. The inter-rater reliability of the classification is 0.88, meaning 88% of the time surgeons would agree on reading a specific complication or where it belongs, and it correlated very well with how patients do after surgery, meaning there was what we call the external validity. So the severity of the complication correlated with how patients did after surgery. We looked at the nature and patterns, and obviously it depends, and this is only some examples. In intestinal surgery, a lot of bowel injuries can occur, and this is published in the American Journal of Surgery. hepatopancreatic biliary surgery, a lot of vascular surgeries occurring, and foregut surgery like bariatric surgery, a lot of injury to the surrounding organs like the spleen, for example, or the liver are injured during surgery. But we also discovered that 48% of the intraoperative injuries or intraoperative adverse event occur during lysis of adhesions. So whenever you have the redo surgery, that's major risk, and it happens during adhesiolysis, not during access to surgery when you're doing laparoscopy. It happened during the dissection phase. And injuries happen again during the dissection rather than the reconstruction and the resection. In 11% of the time, it resulted in intraoperative consults, and that's not somebody calling surgeon of the same specialty. That's a surgeon calling a surgeon from a different specialty to come and assist in rescuing the patient. And for those cases that were laparoscopic, 16% of them had to be converted to open to deal with the intraoperative complication. When we looked at predictors, this is another study. We looked, okay, what things do predict that a patient is at risk of having a major intraoperative adverse event? And we use something called relative value unit, or RVU, which is a measure proxy for how complex the surgery is, the open surgery technique. Most important was adhesiolysis. So redo surgery is a very important marker that this patient is at high risk. So why is this important? This is important because if you're comparing surgeons or comparing hospitals, and there's the referral hospital that does all the complicated redo surgeries, if you don't enter that variable, you don't measure how many redo surgeries they're doing, then the hospital taking the more difficult cases will look like they have higher rate of complications. But if you adjust for that factor, then you can actually show that that hospital might be the better one, the one you want to go to if you have a complicated or redo surgery. Now, how does the occurrence of an intraoperative mishap or an intraoperative adverse event affect patients? Does the occurrence, if you fix what went wrong in surgery, does it end at the doorstep of the operating room, or does it spill over to the ICU and to the floor where you're taking care of that patient? This is this study published 2 years ago in the Annals of Surgery, and it's called Intraoperative Adverse Events and Abdominal Surgery. What happens in the operating room does not stay in the operating room. And this is what we found. So for those of you who are savvy with statistics, these are the hazard ratios. One meaning this is what you expect. Like if it doesn't affect anything, then everything should be 1. And this is for specific complications after surgery. So if a line crosses 1, that means, yeah, if you fix it during surgery, no worries, no problem. And what you find is everything being equal. If you injure something during surgery for the same type of patient, that patient you injure something, even if you fix it during surgery, they are at 3 times the risk of dying after surgery. They're almost at 2.5 times the risk of having a major complication like renal failure, pneumonia, surgical site infection, you name it, after surgery. They stay longer in the hospital. They have a much higher risk of surgical site infections. They have a much higher risk of sepsis after surgery, a much higher risk of pneumonia after surgery, and a much higher risk of failure to wean off the ventilator, meaning acute respiratory failure. What does that mean? I mean, if you think about it for a second, you know that patient. The surgery goes well, patient does well, recovers, goes home without a problem. But you injure something during surgery, next thing, the patient is having more pain, next thing, they're not breathing well, they get intubated, they get a scan, they have an abscess, they get a drain, the drain leads to, with the contrast, they get a drain, they get renal failure. It's almost like a snowball effect. So what happens during surgery affects at the core of how the patient will do after surgery. And this is why it's important that we measure these safety-related events and these complications during surgery. They do not stay in the operating room. They affect how your patient will do and the chance of them recovering, even if you think you already fixed it during surgery. We looked at readmissions. You can see the patient who has a major intraoperative adverse events is at twice the risk of getting readmitted to the hospital because of complications of their surgery and complications of what happened. If you look at financial impact, if there's anybody in the finance department listening to us, again, everything being equal, the charges and the cost to the hospital, to the system, to the patient is 43% higher when something goes wrong during surgery. And that's, again, everything else being equal. And that, for example, instead of, this is on average, $27,000 becomes $13,000. So there's a cost. This is with an injury and without an injury. And if you divide it into direct and indirect cost, the same thing, higher indirect cost and a high direct cost. And we know that the patient you injure is the patient who you require to do more stuff in surgery, requiring more equipment. You order more x-rays on that patient because you're worried about them. You order more labs and more information on those patients, so the cost of the labs and the radiology and x-ray is higher. Or these are the patients who need tube feeds and TPN, so they get more. And you can see that the cost is affected. So there's a big burden to the system and to the hospital and to the patient related to these intraoperative adverse events. Told you we looked at operating at night, and it turns out if you have the right systems in the hospital, it didn't pan out to affect, so it didn't matter if somebody needs immersion surgery at night, it's okay to operate on them at night. If it's an elective surgery, probably better to wait till the morning to do it because that might decrease the risk of problems. How about surgeons' experience? How about the trainees' experience? And this is what we found. Surgeons who have more than 20 years of experience in the type of surgery they're performing, compared to those in the first 5 years of experience, they have much less rate of intraoperative complications. And again, this is for the same type of patients, for the same type of surgeries. If you have more than 20 years experience, your experience results in less errors and less complications during surgery compared to the first 5 years of experience as a surgeon. However, the resident, the trainee, we can't blame this one on the resident, folks. It's the attending and the surgeon, not the trainee, that affects that. We looked then at the impact on surgeons. And the last part of my talk, we'll talk a little bit about it. But we did look at how does it affected the surgeons themselves or the nurses or the anesthesiologists when we do injure a patient, especially when we injure them bad and they don't do well. I'll talk more about that. But to finish, we talked about what level do we benchmark. So we should definitely compare outcomes across different hospitals. That's the only way of us knowing, are we doing okay? Are we not doing okay? Are we doing safe surgery? Are we doing high quality surgery? How do we compare to the average hospital in the country? Should we aim for better? Are we doing okay? Should we teach other hospitals how we do? We probably should do it at the specialty level too, because doing a hand surgery is very different than doing a spine surgery. It's very different than doing an abdominal surgery. Abdominal surgery, a pancreatic resection is very different than a colorectal surgery. So we should be doing that. I think it should be maybe at the surgeon's level. I don't think we have enough numbers, enough granularity to account for all the different risk factors so we can do a meaningful comparison at the surgeon or the physician or the nurse level. Having said that, I'm a big proponent of you give each provider, each surgeon, each nurse, each anesthesiologist their data compared to how they compare to everybody else. But they would be the only one looking at it. You tell them nothing about it, and that by itself can drive quality improvement. So why is risk adjustment critical? Because you really, really do not want to penalize the hospitals and surgeons who take care of the highest risk patients. You do not want to discourage hospitals and surgeons from taking care of the sickest patients. You do not want to incentivize cherry picking. Suddenly that patient who has the most difficult cardiac disease has been operated on twice but is about to die, but nobody wants to operate on them because if they die, they get penalized because they have a death in their hospitals. You want to create enough risk adjustment that you can encourage these hospitals to take care of the sickest patients because you're measuring how sick they are, and you can know that even though they died, they were a high-risk patient. They were gonna die anyway, so you can, discourage this cherry-picking component. There's multiple ways of doing risk adjustment. This is what we call observed or expected ratios, which this is a graph that comes from NISQIP, for example. And you can see for specific specialties or for overall, each hospital in the United States is one line here. And this is the average. You can see where the line goes. So this is observed over expected ratio. You get the expected from the average in the nation. That's why it meets in the middle. So if you are a hospital that is shows on the pink side, that means you have a high observed over expected ratio, meaning you have more deaths and more complications than you should have for your case mix of patients. That means you have a problem here, and it's up to that hospital to figure out, why am I not doing well? On the other side of the graph, you see the green, and that means your observed over expected ratio in your hospital is lower than 1, which means you actually have less deaths and less complications than what is expected for your type of patients, meaning, yeah, maybe these hospitals need to hook up with these hospitals, see what they are doing right. And one hospital could be doing very well in a specific complication and not be doing so well on the other. So hospitals can cross-share their processes of how to do things to all improve together, and encourage sharing of information and sharing of best practices on how to improve safety. However, it's also important that we cannot compare apples to oranges. I think the comparisons should be very field specific. This is another study we did. For example, we used to, in the United States, to compare all surgeries together and in the same model of risk adjustment. But it turns out that perioperative risk factors affect outcomes very differently in the cases that you have to do emergently versus non-emergently. And perhaps, and we did since then, separate our risk adjustment models for emergency versus non-emergency. At Mass General, we use all these models, we review quarterly, and we do an annual meeting where we share all this data in a very confidential meeting across everybody in a transparent fashion, because we all can learn from each other. Each model brings strengths and weaknesses. The whole picture is better understood by removing all the data. If your hospital is consistently, whether you use administrative data, clinical data, different sources, you still show up as you have a problem in surgical site infection, then you probably have a problem in surgical site infections, and you should look at it in more details. Again, when a signal appears in multiple measures, it's real, and you better start working on improving it. Why is this important? Again, you are a patient and you need to have surgery. You want to have the safest surgery. You do not want to have an injury during surgery. You look at hospital X and hospital Y, and if you look at their crude complication rate, let's say hospital X has 4%, hospital Y has 8%. So if you don't look at the bottom, you're going to say hospital X is clearly better than hospital Y, and you should go and have your surgery there. And what I say is, wait, you need to do risk adjustment, and you can mathematically adjust the rates of complications per the risk. So if hospital Y takes care of sicker patients who have redo surgeries, then when you do this adjustment, now the numbers look like hospital X has 5% instead of 4 risk-adjusted rate of complications. Hospital Y has 6%. So you go, okay, well, still hospital Y is worse, so I should go have my surgery in hospital X. And it turns out that's not necessarily true either, because if you do severity adjustment, it turns out that hospital X has very problematic complications. They're very severe complications. Hospital Y has very small injuries during surgery, and therefore when you do the calculations, looks 5% versus 4%, and suddenly the recommendation would be you should have your surgery in hospital Y instead of hospital X, which is the opposite of what you would have done if you only looked at the crude complication rate. And deriving that such risk-adjusted and severity-adjusted rates of adverse events lead to identify areas of improvement, whether your surgeons need more proficiency, they need to have more experience, they need to be doing some of these surgeries with more experienced surgeons, or whether your system itself needs to design more slices of cheese to make it safer, is what you can identify by measuring things and measuring them accurately. Now, what can you tell patients? Now, we know that a lot of these complications happen because of the risk factors of the patients themselves. Can you tell patients what is their risk of complications? What are the risk of actually dying from surgery? So if we take another case, we say you are about to get in your car to go home and see your kids, and like it happens in every day, you get a page from the emergency room. They tell you you need to come see Marie. Let's say Marie is a 75-year-old lady who is reasonably healthy, has some comorbidities, and a day ago started having abdominal pain. And she said, oh, maybe it just, I have a little bit of constipation, I'll wait. Then the next day their family brings Marie, and Marie is now sick, having her blood pressure is low. She gets intubated because she's not breathing very well, and is on vasopressor because she is not doing very well. You do a CAT scan, you see that Marie has free air, she has some kind of bowel perforation, and she needs surgery. What should you tell Marie? Should you tell her she will make it from surgery? She will not make it from surgery? Should her family be worried? Should they consent to the surgery? Should they say she lived enough? She's 80 or 75, whatever she is. Is she going to make it? What can you tell her? And that's the next few slides when I show you. The problem is the existing risk assessment tools we have are long, they're very difficult, and they underperform. And that's not me saying that. If you look enough in the literature, there's plenty of data saying the ACS risk calculator, which is one of the most commonly being used in these circumstances, actually underperforms in multiple areas, in colorectal, in gastric cancer, in cystectomies, in head and neck surgery, in the elderly, in the very elderly patients, it underperforms. So we designed a few years ago, a research group, something called the emergency surgery score. It's like the injury severity score for trauma patients, but it's a very reasonably simple score. If you have this patient like Marie, you can have a point system that you can give them a point numbers here. For example, if they were older than 60, they get 2 points. If she has COPD, she gets 1 point. If she got intubated before surgery, she gets 3 points. If the white count is 25, she gets 2 points. You calculate the number of points. And what we found in that study that was published also about 4 years ago, that as the score goes up, so if Marie had 4 points on the emergency surgery score, it predicts the rate of mortality is about 3-4%. But if her score is 10 points, mortality is about 30%. If the score is 17 points, she becomes about 65%. And once you reach about 20 points or 19 points, you're talking in the 90 to 100% range of mortality. The same thing, you have here the ESS number of points. You have here the rate of complications after surgery. And you can see that for a score of 3, for example, there's a 20% chance of Marie getting a complication. For a score of 10, she has a 73% chance of getting a complication. And once you're at a score of 15 and above, you're in the 90 to 100% range of getting a complication like pneumonia, renal failure, surgical site infection, and everything. And you have the details on the specific complications during the paper. We could even use ESS if they're going to need the ICU. If you don't know if this patient is going to need the ICU or not, you calculate the score. If they're a score of 9, they have a 40% chance of needing the ICU. But if their score is about 14 to 15, you have a 90% chance that they will get a complication that will need the ICU, and it might be prudent to triage that patient to the ICU rather than send them to the floor so that we don't fail at rescuing them. However, we created ESS, but then we realized something that's very fundamental, that ESS, as good as it is, and it performed very well, had a C statistics or area under the curve of 0.86, still presumes that the impact of risk factor is linear and you can just add them. The truth of medicine, and if you are a practicing physician or if you're a practicing nurse, you know that's not how it works. If you have a healthy patient compared to a patient with hypertension, you know that hypertension increases the risk of a lot of complications. However, if that same patient is a patient with liver cirrhosis, then you know that hypertension is not making a difference anymore. So the presence of certain risk factors affects directly if other risk factors matter or do not matter. In other words, surgical risk is not linear. And that put me and my team on a journey to like, well, can we do better? Can we predict Marie's risk of complications better than we do? So right across from Harvard, there is MIT, Massachusetts Institute of Technology. They're the math whiz. They are the engineers. And this is kind of the area artificial intelligence was becoming more of a reality. And we wanted to collaborate together. So you can see actually in this picture, I don't know if it projects very well, this is the Charles River in Boston with all the sailboats. And right here is Mass General Hospital. And right on the other side of the river is MIT. So we crossed this bridge and we started a collaboration a few years ago. And we said, we want to do this better. So we used the artificial intelligence power that MIT had and the big data power that our research team has at Mass General and Harvard. And we said, let's do something better. We wanted to use these novel and non-linear machine learning techniques to design an interactive and accurate calculator to predict the risk of mortality and morbidity. And we started with emergency surgery. And later on, we worked on the elective surgery. So that we don't think this is a futuristic thing. We're not talking about robots. In case you did not notice, artificial intelligence is all around you. There's multiple areas. There's machine learning, which is what we used. There's natural language processing. There's speech recognition. That's when you ask your phone, Google, or you ask Siri. This is artificial intelligence speech recognition. Robotics is one of them, but there's also image recognition. This is the ability of a machine, an algorithm to look at a figure. This is when you have the face recognition, for example, on your phones. That's artificial intelligence. Again, this is the phone. This is your Siri. This is all around you. But it's even more than that. If you visit San Francisco, you might have noticed that there are a lot of cars are driving now with nobody behind the steering wheel, or some people behind the steering wheel, but they're really looking at their phones and not looking at the road. This is the image recognition where your car can look and identify that there's a biker here, they're going at a specific speed, and it helps you with when you should brake, when you shouldn't brake, when you should accelerate, and all of these. And all the cars now have some form of image recognition. Machine learning is different. So what is machine learning? Machine learning is you have a lot of data, you clean, prepare, manipulate the data, then you use a lot of your data to train the model. So it goes by trial and error until it starts figuring out relationships between different variables that the human mind is too simple to figure out this relationship. And then it figures out the best algorithms to predict the risk. Then you test the data on you test your algorithms on a different data. And the trick is every time you tell your algorithm if it got the answer correct or not, your algorithm keeps correcting itself. So machine learning, and we used the NScript database that I already mentioned. We used about 6 years of data from across the whole country. We used 1 year of the data to validate the model. And we use something called the optimal classification trees, which is a special type of machine learning. And as you can see, it's almost like decision making of going through thousands and thousands of algorithms. And this is what AI, like I told you, it's continually learning from its mistakes. It's adaptive, it's interactive, reboots itself with each variable, and accounts for the nonlinear interactions among variables. So this is where it is. It's interpretable optimal classification trees. Its performance is so much better than everything we have. And we also wanted to create an online and phone application which serves as the complex algorithms, the predictive algorithms, interactive and user-friendly interface. So this is the paper. It was presented at the American Surgical here, which is the top meeting we have in the country. Surgical risk is not linear, and we derived what we call the Potter calculator, which is the predictive optimal trees and emergency surgery risk, and it's published in the Annals of Surgery. We had about 400,000 patients. The number of trees needed for any specific question is 4 to 11. I'm going to show you how to do these, but this is the performance. This is how the algorithms look. They're too complex, but give you an idea of how the complex mathematics behind it. The performance, what we call the C-statistics, is 0.92. In medicine in general, when we are above 0.75, we all say, this is great. You're talking 0.92. This is really, really accurate. When you compare it, this is the Potter calculator compared to everything that we have, like the ACS NetScript calculator. Its performance is so much better in predicting mortality. When you look at complications, 0.85, you compare it to the other ways we have to model risk, it is so much better. This is machine learning AI, performance is way superior. When you look at specific complications, for example, septic shock or acute renal failure or respiratory failure, you can see its ability to predict reaches about 0.93 and 0.94, meaning its accuracy is way, way higher than anything we have. And now I'll walk you through this calculator that I encourage each one of you to pick up. If you have an iPhone or an Android, you can download it very readily. It's available, it's free. You can download it. If you look up Potter calculator. And this is how it works. Let's go back to Marie. Let's see, what are we going to tell Marie's family about her chances of making it through surgery and what kind of complications could she have? What will you be telling her? Actually, I'm going to take two patients of mine. Marie was a patient of mine, and this is a patient we shall call Heather. I'm changing the names just for patient confidentiality. And they are two different patients. And the reason I chose two patients because I want to show you how the algorithms work. Let's say Heather is a 21-year-old who has a much simpler problem that needs an emergent surgery nonetheless. When you open the Potter calculator on your phone, you can choose to predict mortality, any complication, or a specific complication. For Marie, the first question the algorithm wants to know if she is now in respiratory failure. You say yes. You say she's 85 years old. For Heather, she is not intubated. She's only 25. So now notice how the algorithms change. For Marie, it's asking about the INR of Marie. Now, I don't know, as a surgeon, it's not the first thing that comes to my mind. But the algorithm predicted that for that age group, for this patient, INR matters in the algorithms now. Put a 1.9. For Heather, it's a totally different question. The algorithm is asking about the BUN, about her kidney function. You enter the information for both, 1.9 for INR and 1 for BUN. Then it's asking for Marie about her bilirubin level. For Heather, it's asking if she has disseminated cancer. Very different questions, very different algorithms. You enter bilirubin of 4 for Marie. It gives you that her mortality rate is 70.46%, which is based on the fact that 446 patients out of 633 patients with the same characteristics like Marie and the 400,000 patients that we have died. For Heather, the algorithm is still asking. It says, is the patient septic? You put that the patient, yes, has sepsis, asking if she has a bleeding disorder. You answer the question as yes, asking about albumin, you put 3.5, and this is when the algorithms finally spits out the result. It says she has a 5.47% risk of dying from surgery, which is based on the fact that 83 patients who had the same characteristics like Heather, 83 patients died out of 1,518 patients who had the same characteristics. So you can see the way you answer a question in the calculator dictates what the next question would be. So it's a novel adaptive calculator. to predict outcome in the emergency surgery patients. It's very accurate, it's nonlinear, interactive. You can integrate it in your medical records, potentially actionable, and it's very important to set the expectations right for the family and their patients before you take them for surgery. Right now, through my Center for Outcomes and Patient Safety Surgery, the algorithms we're trying to derive, we actually have many of these algorithms for the multiple departments that we have in our quality and safety umbrella. We have similar algorithms for pancreatic surgery, for liver surgery, colorectal surgery, trauma surgery, and so on and so forth. We have even one that is in progression for orthopedic surgery. We are trying to integrate it with Epic, which is the medical record system that we have, so it becomes part of our informed consents. And this is where the world is going to be going. You know, our gestalt, our feeling of how the patient is doing is not enough. Now, this takes me to the last part of our talk, which is what I call the second victim phenomenon. And this will take about 10 minutes, and after that, I'll be happy. We'll see if the webinar format allows us to take questions. But this is one that's dear to my heart. This is a case that I wanted to bring to your attention. This is a case of mine. This was many years ago. I was very early in my career, and I had a trauma patient that was pinned by a forklift in a construction and had a major injury to their pelvis. I operated on this patient 6 times within the first 72 hours. They had bleeding in their pelvis from a fracture. They had a big hole because of the forklift. So they had a rectal injury, a bladder injury. They had injury to both iliac vessels. So I had done ligation of both iliac vessels. I had reconstruction of their femoral vessel. I had done a colostomy, a bladder repair, and the patient was critically ill for many, many days. And on day 4 or 5, the patient started getting better, and we had finalized all the surgeries we did. So I went and talked to his mother, and he had 2 kids, a 14 and a 16-year-old kids. And I told them for the first time that their father might actually make it out of this critical illness. The patient was doing well in the ICU, and I was finally starting to be optimistic. And for the first time I had stayed in the hospital, like I told you, for 3-4 days, operating twice a day. I thought I can go home. And I went home and I slept for the first time in 4 days. And at 1 a.m., 2 a.m., my partner, who was covering the hospital, calls me and says, "Dude, your patient's going down the drain." And that's an American slang to say, my friend, your patient is not doing well and is dying right now in the ICU. I rushed to the hospital, and that patient was very, very sick now. I left him doing well, and he was very sick. And he developed what we call a necrotizing skin and soft tissue infection that was so bad that we couldn't salvage him from it, and he died that morning. Now, the reason I'm telling you the story, the reason I have this picture is on the morning when I told his mother that he actually is doing finally better, she went and made all these cookies for me, which I shared some of them with the staff, and then I took the box with me, which was a beautiful box you can see here, and I shared it with my, back in the days, 5-year-old daughter who loved that box. She still loves the box, and she keeps it in her room. This is her room. And still to today, this is many years later, I still see the box, and every time I see it, I remember that patient. Now, the reason that patient affected me, not because I'm not used to patients dying. The trauma and acute care surgery, it's high acuity. A lot of patients die. But because on the last surgery I did for the patient, I kind of noticed that the fat was a bit dull. And if you're a surgeon, you know what I'm talking about. It just did not look shiny like it should be. It was okay, but it didn't look great. But in the back of my mind, I was beating myself because I felt like there was the beginning of that infection that I missed as a surgeon, the early signs of it. And I felt that I failed that patient, and that's why his family doesn't have them. It affected me deeply. Until today, I still feel that I failed that patient. And I think many of you who have taken care of patients, when you feel you failed the patient or you injured the patient, it can affect you deeply. And this is the topic. And I know that many of you have similar stories, and you might not be able to share them on these, but feel free to email me and share your stories with me. Because what I wanted to talk to you about is this. So when things go wrong, the surgeon as the second victim. Because we're not known for being warm and cuddly. Surgeons are not. We're sometimes arrogant, impatient, we're sometimes mean. And some people think we don't have friends. I know we all do, but who could stand us, right? We're sometimes wrong. We're never in doubt. We think a good surgeon should have the eyes of an eagle and the heart of a lion. But what many surgeons know, that out of suffering have emerged the strongest souls, the most massive characters are sealed with scars. And this is what I want to talk to you for the last 10 minutes about. All physicians and nurses are subject to the same phenomenon. There's no question. But why are we focusing on surgeons? The reason I'm focusing on surgeons is because it's a low-hanging fruit. But also we have a strong culture of mistake ownership and responsibility. When we do something that doesn't go right, most surgeons own up to it, and take responsibility for it. But we also have the persona that a surgeon is unbreakable, is very tough, cannot be shaken by anything. But also when we injure somebody during surgery, there is something to be said when we injure physically a patient and we feel almost like we stabbed them, we did something wrong. When we injure the aorta accidentally, it feels like we really harmed them directly. It has a different sense to it. The whole idea started going back when I was trying to study intraoperative adverse events. And we wanted to study how it impacts surgeons. We did this questionnaire to all the Harvard hospitals. There's 4 Harvard hospitals, and we applied this questionnaire to study mostly the emotional response to intraoperative adverse events. And what we found is the following. So the survey had relatively older surgeons. 65% had more than 10 years of experience. All specialties were represented: cardiac, general, pediatric, thoracic, transplant, and trauma. And most of them are very busy surgeons. 83% performed at least 150 surgeries a year, and most of them were more around 250 surgeries a year. And most surgeons, 90% of them, have dealt with some major intraoperative adverse events since finishing training. You can see how many had 1 in the last year, how many had 2 to 5 in the last year, how many more than 6. Then what we found, when we asked surgeons about the emotional impact, 84% of surgeons reported some major feelings of sadness, anxiety, anger, shame, embarrassment, as well as feeling really, really down. When we looked at young surgeons versus experienced surgeons, it did not matter. When we injured patients, the way we feel was unanimous to everybody. But what was most important, I had left a little bit of room in that survey for surgeons who wanted to write stuff. And surgeons, I don't know if any of you have trained in the Harvard system. This is not a touchy-feely place. This is where surgeons are very tough, very macho to a certain extent, and nobody shares their feeling easily. But this is a comment from that survey. A surgeon wrote, "We all hide our grief, suffer in silence. The pain can be close to debilitating." When we ask them who helps them the most, colleagues, not family members, were the people they go to. And 42% of them chose to go to their colleagues to talk about how they feel when they really harmed the patient or a patient under their care died. And a few surgeons even needed psychological therapy and counseling because of the severity of the injury to the patient. More comments, all related to patient safety. Everyone knows about an intraoperative adverse event within moments. No such thing as a support system, only criticism and condemnation. The competitive and state-of-the-art culture of surgery at one of those 4 Harvard institutions makes it difficult to seek out support openly. The responses at mortality and morbidity conferences to adverse events is personal, critical rather than constructive, even though everyone encounters such events in a while. Quality and safety is more focused on blaming surgeons rather than solving safety issues, makes a difficult emotional time even worse. So This is like what they thought is a barrier to reporting intraoperative adverse events, most importantly, the fear of litigation, which is a big problem in the United States, but also the lack of a standardized system to management. However, what came out of that survey is we need to create a way to support our surgeons. And that's what the BISA study, the Boston Intraoperative Adverse Event Surgeons Attitude Study, presented a challenge to us. So the second victim phenomenon is not something that new. Nurses are exposed to it. Physicians are exposed to it. Even allied staff, the respiratory therapist might be exposed to it. It affects everybody who touches patients. And it affects everybody that is exposed to patients not doing well or injuries to patients. The first report I found in literature for the second victim phenomena comes from this OBGYN surgeon in the New England Journal of Medicine who aborted what he thought is a dead fetus and turns out to be an alive fetus. The pathology report confirms my worst fears. I have aborted a living fetus. Over the next, this is Dr. Hilfiger back in the 70s or 80s. Over the next few days, my guilt and anger grew. I discussed the events with my partners. We see the horror of our own mistakes. Yet we are given no permission to deal with their enormous emotional impact. At some point, we must bring our mistakes out of the closet. We need to give ourselves permission to recognize our errors and their consequences. We need to find healthy ways to deal with our emotional responses to these errors. Our profession is difficult enough without having to wear the yoke of perfection. Albert Wu, who's a very good friend of mine in Hopkins, this is a study from him or an editorial from him in 2000, talking not only about surgeons, but all physicians, and the same applies for nurses. Virtually every practitioner knows the sickening realization of making a bad mistake. You feel singled out, exposed, seized by the instinct to see if anyone has noticed. You agonize about what to do, whether to tell anyone, what to say. Later, the event replays itself over and over in your mind. You question your own competence but fear being discovered. You know you should confess but dread the prospect of potential punishment and of the patient's anger. You may become overly attentive to the patient or family, lamenting the failure to do so earlier, and if you haven't told them, wondering if they know. I know a lot of you listen to this and feel that sounds like an experience of mine in the past. It does ring a bell. People have studied it. This is for physicians, how it affects increased anxiety for physicians when things go wrong, decreased job confidence, decreased job satisfaction, increased sleeplessness, and harm to professional reputation. The same thing happens for nurses, extreme sadness, difficulty concentrating, depression, sleep disturbances, and avoidance of similar types of patient care. This is a very high visibility case. This is a Kim Hyatt who was a pediatric ICU nurse. And Kim Hyatt did a mistake where she gave too much calcium to a patient, miscalculated the correct dose after working for 25 years in the ICU. The patient died 4 days after the error. She got completely demoralized. She was crying. She was actually fired from the hospital while there was an investigation happening. The investigation took 5 months. What happened is Kim took her own life 7 months later. And I know at least of 4 similar cases of physicians in the last 2 years that happened in the United States. Sometimes the effect on physicians and nurses could be devastating to the point of taking their own life, unfortunately. And this is how her colleagues described Kim Hyatt. So again, the problem is not only surgeons, the problem is surgeons, physicians, nurses, and everybody who works in the healthcare and takes care of patients. So what helps? We know that what helps is talking about it, acknowledging the mistake, holding the feelings, emotional impact, knowing you're not alone. Talking to peers is very important. Disclosure to the patient or apology helps. Dealing with imperfection, learning how to become an expert in that field, becoming a patient safety advocate for that specific problem can help. Peer support programs can help. And that's what I want to show you what we've done at Harvard, at Mass General Hospital in the last few years. So this is coming from the Brigham, and I'm going to skip to show you what we did at MGH and report some of our early results. So after the BISA study here at Harvard, the Mass General, we said we need to do something different and talk about our mistakes more openly. So we created what we call the MGA Surgical Peer Support Program, the program that I direct myself here, where we intervene when there is major surgical errors like intraoperative adverse events, catastrophic outcomes, and lawsuits when a surgeon is being sued. We started by designing a conceptual framework, choosing the peer supporters that we will send to the peers that are affected by these events, training them appropriately, identifying the major adverse events, and creating an intervention plan to deal with it. So we created a sense of urgency by sharing the results of the PSI study and the comments from everybody. We got everybody in the institution to agree on it, from the safety, the quality personnel, as well as the chairs of the departments. We placed it under QA, but separated it from QA so that it is protected from litigation. Then we chose the peer supporters by making surgeons vote for who they go to when they have such events. So, and then we chose who were voted recurrently, and they were the peer supporters. Then we created, it's a very complex training program that we created. We create protected time for the training session, how to actually support your peers, and there's a lot of techniques. For example, surgeons and physicians and nurses were all problem solvers. Whenever somebody is talking to us about a major complication they had, our first reflex is we want to jump and help resolve the problem. That is exactly the opposite of what you need to do as a peer supporter. You need to fight your instinct to jump and help, or to jump and tell them, oh, it's not a big deal. And that's actually the opposite of what you need to do. So some of that training needs to be systematic and change some of the habits we develop as surgeons to how to support our peers. Then we created a systematic fashion of how to identify what situations we need to intervene on through M&M, mortality reviews, quality directors, safety reports, but most importantly, word of mouth. And we had a systematic intervention plan. There's an outreach email that I sent personally to the affected individuals, and this is one of the emails I tailored to the specific situation. For example, it came to my attention you were involved in a difficult patient complication. We all have been in similar situations. I know they can take a large toll on us, even at subconscious level, if we don't discuss them. I'm reaching out to you to make sure you're doing okay. Would love to buy you coffee tomorrow if you're free. Not everyone needs it, and so on and so forth. We give them resources about the phases of recovery from the situation, and we made it an opt-out instead of an opt-in. So only if the surgeon says, I do not want you, I'm doing okay, thank you, we don't intervene. Otherwise, we reach out, and most of the time, it's a simple conversation over coffee to tell them, we know how it feels, we support you, and get over it. So in the first year of the program, we're now on the second and third year of the program, we had 47 outreach intervention. I mean, I don't know if you know Mass General, but this is a 1,300 beds. We have 126 operating rooms. It's a very, very busy place. Every operating room is used every single day, including the weekends. 47 outreach intervention to multiple attendings, as well as trainees from all surgical specialties, all levels of training for the residents, and most interventions related for major intraoperative mishaps, including intraoperative deaths, or unexpected catastrophic patient outcomes. 19% of the surgeons who reached out said they opted out and did not need intervention. When we asked a year later how they feel about it, the surgeons who were involved, meaning we reached out to them, most of them, blue is good. This is the majority saying strongly agree. Blue, yellow, and gray are the best, and orange is not so good of a response. They thought that the peers provided a safe, trusting environment for discussion, felt comfortable voicing their concerns. My peer was non-judgmental, was an attentive listener, supported me in making changes to practice, helped me feel better, was satisfied with my experience with my peer supporter. When we asked people about the peer supporters, they said it was easy to set up a time to talk to them. They felt comfortable listening to their colleague, satisfied with the colleague's improvement, did not consume too much of their time, and would like peer support for themselves if they experience a challenging case. 2 peers were referred to the psychologists in the hospital because they were very distressed and not doing well, and 1 was actually suicidal that needed actually to be referred to the emergency room for an emergency psychiatric assessment. All the people who evaluated the program, they were satisfied with confidentiality, timeliness of intervention, and recommended the program to colleagues, and they wanted to become or continue to be a peer supporter. So long story short, the most important part was that 81% of people said there was a positive impact on our safety and support culture. Again, Mass General Hospital, it's a hospital that's been around since 1811. We talk about ourselves as 200 years of tradition, unimpeded by medical progress. Our M&Ms are very cruel and very critical, which is for a good way, because we care about patients. We want to get to the bottom of why a problem happened, why a complication happened. But the change that our program has had is we're still very critical of each other, but in the hallways when we get out, I know I get these phone calls to reach out to make sure some surgeon is doing okay and is not beating themselves too much to the point of not being able to perform well. So we reached out and helped them. So I know it's been, I said we're going to leave 15 minutes for questions. We covered, just to summarize, we covered several topics. We talked about patient safety in surgery, from blame to safe system design. We talked about the importance of measuring to improvement. You cannot improve what you do not measure. What you do not measure, risk adjust. What you do not measure, risk adjust and benchmark across different hospitals, different surgeons, and different specialties. We talked about how to predict the outcomes, how to predict safety-related adverse events, and finally, we talked about how to take care of each other when these safety events happen, how to make sure our colleagues are not going down the wrong pathway. That's all I have for you today. I hope you enjoyed it, and I'm gonna try to see if I can get your questions and see if I can answer them. But I'm also interested in hearing your similar stories, so go at it. I think I'm going to put myself on mute, and I'm going to try to answer the questions on the questions tab there. Let me know if it's working or not. I think it's taking a little bit of time for me to write, so I'm going to just answer them as we go. For Nada, is asking about should we tell patients specifically they need a blood transfusion if they bleed? I think our consent forms specifically spell out that in case there is need, if they consent to blood transfusions or not. So I encourage, when you do discuss with patients, you do mention the blood transfusion is needed. Abdul Muttalib is asking, is Potter available for Epic users? And the answer, not yet. We are working on integrating with Epic, so stay tuned, and hopefully that will happen soon. So for the informed consent, Nada is asking, for the informed consent, can death be written? Patient consent and patient consent for that. If yes, do we consider sentinel event? How do we deal with this patient safety and risk management if this death is unexpected and only written as a surgical complication? I do think it matters what kind of surgery is being done. Most surgical consents have do not have death as one of the complications. I personally, for the high-risk patients, especially the emergency surgery patients, I add death to the complication, and I do mention it to patients with a little bit of, like, I use the Potter calculator, for example, to tell them, I think your risk of dying is not, is not very high, but it's about 5%, which means the likelihood you want, but it's something that we just need to mention. Let me see. Do you have the second victim program for the surgeon specifically? So this is Mekia Majrashi is asking, and the answer, yes. Actually, I strongly believe that any peer support program needs to be, specialty specific. So if a psychiatrist has a second victim phenomenon, I do not know how to talk to a psychiatrist about their patient who committed suicide, because I do not deal with these patients. So a lot of the peer support comes from the ability to say, I've been in your shoes, I know how it feels, and it's okay, time will heal, time will pass, and you'll feel better. So the ability to identify with your peer who's suffering from that phenomenon is important. So it is surgery specific in our program, but I can send a vascular surgeon to talk to a cardiac surgeon to talk to a general surgeon, and so on and so forth. Makia is asking, what is the recommendation of tools to actively engage patient before and after surgeries for patient empowerment? I believe in personal communication. I engage them. It takes an effort to listen to the patients. And if you find yourself interrupting the patients 10 seconds into the conversation, I think you should train yourself to not interrupt the patient. Listen to what they have to say. Listen to what's concerning to them, and you'll be amazed of how much engagement you can get from these patients. Mikia, so what is your recommendation to encourage correct coding by doctors? I think it's a big discussion. I don't think we have time to go into details, but I think educational interventions that are specific to what these doctors most commonly do can improve coding accuracy. So, if I'm a trauma surgeon, I never do, let's say, I never do a tonsillectomy. I do not need to know the details about how to code a tonsillectomy. But for things relevant to my practice, I think targeted interventions would be helpful. Kia is asking, after getting data from PSI, decide to have improvement projects, you need to improve the outcomes later. Well, it depends. There's no question that some quality improvement projects, the patients and the families are at the core of the quality improvement initiatives. I give quickly an example of opioid reduction. We have a problem of opioid overprescribing in the United States. And if you want, you can look at it in the Annals of Surgery. We recently published a major intervention across the whole hospital. We decreased opioid prescribing by about 40% over a couple of years. And at the core of our intervention was engaging the patients, and we had brochures for them. We had discussions with them before surgery, after surgery, so that was at the core of it. So if the safety intervention that you need to do it should engage the patient, then yes, you should involve them, and they should be at the core of it. Amateur is asking, what is the difference between re-exploration and unplanned return to the OR? I think if the re-exploration happens in the operating room, that is how it's defined as an unplanned return to the operating room. Now, the key word is unplanned. So if you have a patient that you do the surgery over 2 stages, let's say you have a mesenteric ischemia patient, you do the first surgery, you take a look, you resected that bowel, and there's some that you need to reevaluate. That's not an unplanned return to the OR, and it's not considered a safety-related event. I am seeing Jessa is asking, patient counseling regarding drugs and its side effects, and if patient not willing to accept the medication, now what to do. I personally believe that the only reason a patient is not willing to accept a recommendation is because perhaps we need to spend more time with that specific patient explaining the pros and cons. And perhaps that patient needs more time counseling and listening to them, listening to their concerns and seeing if they change their mind. If they don't, then autonomy comes first. And then we cannot give the medication to a patient that does not need it unless the patient is deemed mentally, doesn't have the capacity to take these decisions. Shahad Al-Quraishi is asking, can we have your email, please? Absolutely. My email is hkaafani@mgh.harvard.edu. I will write it in the answer too so people can see it. Yahya Shaib is asking, will there be a recorded session available? I'll let the the Saudi Patient Safety Center answer that question for you guys. Nawal is asking, can you send your email? I just did. Ilham, yep, same thing. Liakar is asking, where is Potter calculator available? Again, if you, yeah, we answered that. Apple Store for iPhone, Play Store for Androids, and search for Potter calculator. And I have Hilal, I think that's the last question I have. We'll see if there's more that come, is asking how to calculate the qualities life of a patient. Hilal, that's a really good question. It's a very tricky answer. There is multiple tools that exist. We mostly use them for research purposes. And the best one that we use is called SF36, which I'm sure if you do a little bit of search on the internet, you can find it. And it helps. It has multiple dimensions. For example, their levels of sadness, their levels of motivation, but also looks at their ability to perform activities of daily life. So you can use that to measure what we call patient-reported outcomes, or PROMs, and that helps target the quality of life of a patient. And I do think it's a very understudied and underemphasized area of medicine. We do focus sometimes too much on complications. We forget that the essence of it should be the patient and how much of their quality of life we improved or we made worse. So I will try to answer any question about my email. I know a lot of people are asking, but again, it's hkaafani@mgh.harvard.edu. Melissa Olidan is asking, during emergency surgery, is it still recommended to do the surgical safety checklist? Melissa, this is an absolutely excellent question. And it's, I think actually this is where we need to be using it the most. You have the emergency patient situation where somebody has multiple gunshot wound and has a cardiac arrest. That might not be the right situation for it. But if the patient situation allows for the 30 seconds or 1 minute to do the checklist, this patient is the one at the highest risk of something going wrong. And those 30 seconds, 1 minute can save you 10, 15 minutes down the road because of miscommunication of what you need, what you're doing, where everybody is on the same page. So I think for emergency situation, it is actually even more important to apply the surgical checklist. I even take this further as saying, if you are in the middle of the operating room and there's a complication that happened, your patient is bleeding, and you can get the finger on that bleeding and take 30 seconds to get everybody in the room together to say, to go on the same page, saying, hey, we have a problem. The patient is bleeding. Do we have blood? Do we have, and go through some, what we call the crisis checklist. It might actually improve outcome. I do strongly believe that it will improve outcomes. Let me see if there's any more questions that I did not. Okay, here you go. Nada is asking, who must take the consent from the patient and explain to him? Can the surgeon who performed the surgery delegate, assign the task for another surgeon? That's a good question, very timely question as well. I think the surgeon performing the surgery should be the one getting the consent. Now, sometimes in surgery, we perform as teams. It could be the trainee getting it on behalf of the surgeon, and I think that's okay as long as it's part of the team performing the surgeries. There are situations where this cannot happen. For example, if you have patients who get admitted overnight for an emergency situation, another surgeon is operating during the day, I think it has to be the surgical team getting the consent, because they can really answer the questions of the patients the best, and this would be an informed consent. Preferably the surgeon, him or herself, but if it's performed by the team, then that should be okay. I think that's all the questions I have. I am sorry if I missed any questions, and that actually brings us to the end of the webinar. Again, I hope you enjoyed. It's kind of a little bit unusual for me not to be hearing the feedback from the audience directly, but I would appreciate any emails. I'm happy if the Saudi Patient Safety Center staff is there. I am more than comfortable with you sharing my emails with any of the audience. Again, thank you so much, and have a good night. Bye-bye.